entire circumference is getting descended down. So that is circumferential descent of the rectum or the bowel through the anal canal. And this can be differentiated into two types. Mainly it is of two types, partial and complete. But another hidden or concealed variety is also told. Partial prolapse and complete prolapse are the main categories. First, it is about the partial prolapse. What is partial prolapse? When only the mucosa and submucosa of the rectum come out through the anus, then it is called partial prolapse. The mucosa and submucosa of the rectum only will be coming out through the anus, then it is called partial prolapse. And the length of the such a prolapse, the length of the partial prolapse will not be more than 3.75 centimeter. And when we palpate the prolapsed mass, that is with keeping one finger inside and the thumb outside the mass, when we palpate the mass as such, we can understand that it is composed of two layers of mucous membrane. So that is the partial prolapse. And the etiology, it is told like in infants it can be due to the sacral curve of the rectum will not be properly developed. So what happens, there is a direct downward course of the rectum and it is easy to get prolapsed. Or maybe because of the diminished tone of the anal musculature there is a descent. In children it is told like it can be because of the faulty bowel habit, it may be because of straining, maybe because of the malnutrition, loss of weight, etc. In adults it is told loss of tone of anal sphincter, then associated with the third degree hemorrhoid, uh, partial prolapse can occur. Then in females there will be torn perineum, that will also cause the partial prolapse. Then excessive straining due to any kind of obstruction, like in case of enlarged prostate and all, there will be excessive straining happening. Or in case of excessive coughing, like in conditions like bronchitis, there will be excessive coughing happening. So because of these kind of strain, excessive strain, prolapse can occur. Then after certain operations, like operations for fistula in fissure in etc., there is so much of stretching to the anal sphincter, that also can cause prolapse. So these are the etiology told for this partial prolapse. And when we see the treatment, conservative treatment, it is told first about digital repositioning of the partial prolapse. That is, in case of infant children and all, the mother is taught to how to replace the protruded bowel. That is, using the index finger, the protrusion should be pushed up through the anal canal, and the finger should be gradually withdrawn. And another things are like we have to take care of the bowel habit, straining should be avoided. Then if there is diarrhea etc, that have to be given with supportive treatments. That is told as conservative management. First one is digital repositioning of the partial prolapse. Next is submucous injection with the 5% phenol in almond oil. That is another conservative method tool. That is mainly in the children after digital repositioning, after 6 weeks trial also, if it is failing, in that condition this submucous injection is advised. What is done is the apex of the prolapse will be injected circularly, and the base of the prolapse should be then injected similarly. And then uh, how the proportion is, that is 10 ml of a solution, 5% phenol in almond oil, that have to be taken in an amount of 10 ml, and that have to be injected in the apex as well as base. That can be done in one sitting, 10 ml can be done. What happens is there will be aseptic inflammation at the site, and later there will be fibrosis, and the mucous membrane will become fixed to the muscular cord, so there will not be any further descent. So that is how the submucous injection with the 5% phenol in almond oil works. The solution have to be given at an amount of 10 ml in one sitting, and this will cause aseptic inflammation, and finally fibrosis, and the mucous membrane will get fixed to the muscular cord, and it will be drawn inside. So that is the conservative treatment methods told. Then operative treatment includes Thier's operation, then excision of prolapsed mass. Thier's operation means we will means when these conservative measures fail, what we do is two small midline incisions. Like in this picture, we will be able to see this one is the Thier's operation. First one is Thier's operation. That is, we will uh, put two small midline incisions. One will be in the front and another will be behind the anal opening. And a long curved needle will be passed from the posterior incision and is passed around half of the anus, emerging through the anterior incision. So you can see how the needle is passed through the behind incision, and it is coming out through the anterior incision, and then the needle is taken out. Then the needle is reinserted through the same incision behind the anus and passed down the opposite side of the anus to emerge through the incision in front of the anus, and other end of the wire that will be threaded. The needle's other end will be threaded and the needle is withdrawn through the anterior incision. Then the index finger of the surgeon is introduced into the anus, and the two ends of the wire is twisted. Then the tightness of the ring have to be appreciated, and when the finger can be just sufficiently passed through the anus, the twisted wire ends are cut short and the anterior and posterior incisions are closed with the stitches. So in this operation, the suture material is passed through the substance of internal sphincter, and that will give a mechanical support as well as a chemical support by the fibrous deposits around the canal. Both mechanical support and a chemical support will be provided this by this technique. That is Thier's operation. And another procedure is the excision of prolapsed mucosa. That is the involved part, the base of the prolapse will be ligated, and this will be transfixed, and then whatever redundant mucosa is there, that is excised, and proper suturing will be done. That is excision of the prolapsed mucosa. These two are the operative treatments suggested in case of partial prolapse. Next, it is the complete prolapse. That is, the rectum comes out through the anus, and the protrusion consists of all the three, all the layers of the rectal wall. Uh, the length when we take, it will be more than 3.75 centimeter in length, and when we palpate between the finger and the thumb, double thickness of the entire wall of the rectum that can be palpated. And etiology, it is told bowel habits. Maybe there will be a long history of difficulty with defecation, then sliding hernia, that can be a reason. When the patient is having sliding hernia, the hernia will be formed with the posterior wall of peritoneal pouch also, that will result in uh, this complete prolapse. Then lack of rectal fixation, that is, the muscles of pelvic floor will be weak and the rectum will be more mobile. And another thing is, the pelvic floor muscles, they will be having disordered function. There will be laxity of the pelvic floor and anal sphincter mechanism due to any cause. These all are considered as the etiology for complete prolapse. And treatment, it is told like it can be fixation operations and resection operations. Fixation operations, that is repair. And in fixation operations comes Evalon sponge warp operation, rectopexy, rectal sling operation, and Delorme's operation and Lahoud's operation. These kind of operations are called fixation operations, which will uh, fix the prolapsed part, or it is a kind of repair as such. And another thing is the resection, the part of the rectum that have to be resected. And in resection operations come anterior resection of rectum, perineal rectosigmoidectomy, operations on the pelvic floor and perineum. So these are the different kinds of resection operations. So when complete prolapse is considered, two kinds of treatment are told: uh, fixation operation and resection operation. In partial, it was conservative and excision, etc. Surgical treatment was told. That is about prolapse. Next is the perianal abscess or anorectal abscess and fistula. So, anorectal abscess are the abscesses which are around the lower rectum and anal canal. They are called anorectal abscesses. Abscesses around lower rectum and anal canal. The causative organism can be Escherichia coli, then it is the most common one, and other organisms like Staphylococcus aureus, Streptococcus, B. proteus, etc. also can be the cause for this anorectal abscesses. The abscess may start as an infection of the anal gland, or it can be an extension of any other infection, like from a cutaneous boil also. The infection, blood-borne infection, can result in the anorectal abscess. Mainly it will be means it will start as a, most commonly it is starting as an infection of an anal gland. Other possibility is from blood-borne infection. When we see the um, classification as such, means when how the anorectal abscesses are classified. uh, First thing is perianal, then ischiorectal, submucous, and pelvirectal. Based on the location of the abscess, these are divided into four. And in perianal abscess, when we see it, the cause is told acute inflammation of anal gland, or it can be an infection of a thrombosed external pile. These can result in perianal abscess. Clinical features, it will be throbbing pain around the anus, then it is an infection. So there will be constitutional symptoms like fever, headache, etc. And when we examine on inspection itself, that it is caused due to an acute inflammation. So an acute angry lump may be seen at the anal margin. It is a perianal abscess. So the abscess will be present at the anal margin. And on palpation, it can be felt by finger in the anal canal just below the dentate line. It is very, very tender and it will be cystic in consistency. And of course, it is an abscess. And when we see about the treatment, first thing is incision and drainage that have to be done under proper antibiotic cover. Cruciate incision have to be placed on the most prominent part of the swelling. Then abscess cavity have to be opened. Then sinus forceps can be inserted, and uh, we will open the blades of the forceps to break the loculi. Means entire loculi have to be no pus pockets should be remaining inside after the procedure. So the all the loculi have to be broken, and adequate drainage have to be done. Then we will use our finger. The finger should be passed into the abscess cavity, and again using the finger all loculi should be broken. uh, and after the procedure, after proper drainage is ensured, the skin edges are incised. That is means after breaking the loculi, if the skin edges are ragged, that have to be incised to keep the wound wide open. We will not suture it. The cavity will be packed with the proper antiseptic or antibiotic solutions, and we will leave the wound as such, and the healing will start by granulation tissue. So that is the treatment. Incision and drainage is the treatment for um, perianal abscess, and that should be done under antibiotic cover. Next, it is about the ischiorectal abscess. That is the cause. When we see, it can be the extension of an anal gland inflammation laterally through the external sphincter. Ischiorectal it is. So again, uh, based on the position, it is considered as ischiorectal abscess. Then the infection can be through blood or lymph. It can be after due to a penetrating injury that causes direct infection from outside, or it can be an extension from some other abscess, some other anorectal abscess. Clinical feature, it is almost same. There will be acute pain. It will be by the side of the anus, and the pain will exaggerate, means it will be exuberant during the defecation. And here also it is an infection, so there will be constitutional symptoms, fever, etc. And on examination, a tender brawny indurated swelling will be felt superficial to the ischiorectal fossa on one side of anus. That will be the location. Treatment, IND is the treatment. There also same thing. Cruciate incision is made. Incision have to be extended, and proper exploration of the cavity is done. Then septa is divided. and whole cavity will be packed with the gauze, which is wrung with the antiseptic solution. Then proper bandage will be done. The wound will heal by granulation tissue, same as that of perianal abscess. Next variety is submucous abscess, that is situated just deep to the mucous membrane of anal canal above the dentate line. Usually it will be from the spread of infection from anal gland or maybe after an injection of hemorrhoids. Treatment is by draining by a small incision and either by stretching the anus or by proctoscope. The procedure can be done. It is a submucous abscess. Next, it is pelvirectal abscess. The location is told like above the levator ani, pelvirectal, pelvic floor, and below the pelvic peritoneum. That will be the location. It is a simple pelvic abscess. It can occur from appendicitis, diverticulitis, salpingitis. That is, infection from either of these can result in pelvirectal abscess, or it can be occurring from a extension of isschorectal abscess. The spread of isschorectal abscess can also result in pelvirectal abscess. Treatment is drainage of the pelvirectal abscess. Next, it is about the fistula in ano. So, when we see anorectal abscess, if the abscess is not properly drained at the proper time, what happens? Of course, whenever there is a pending up of pus or any content is penned up inside, what is that? Either it should be means drained out or it will burst out, or else what happens? It will uh, go inside. That is, it will result in different kinds of tracts below the particular abscess. So here also in the acute phase it is called abscess, and later in the chronic phase, once it is not drained at the proper time, what happens? It will result in fistula. That is, chronic phase is the fistula. Here you can see from the abscess, the fistula's openings can go into other areas. So fistula in it is an inflammatory tract lined by unhealthy granulation tissue opening in the perianal skin and an internal opening in the anal canal or rectum. Abscess which bursts spontaneously. Other reasons associated with these kind of diseases also fistula in ano can occur. Anal fistula can be divided into two groups: low fistula and high fistula. That is, it is based on whether the internal opening is below or above the anorectal ring. Based on that, this division is done: low fistula and high fistula. Low level fistula means it will open into the anal canal below the anorectal ring. That is also further divided into subcutaneous, submucous, intersphincteric, transsphincteric, suprasphincteric, etc., based on the level in which the fistula is opening. Then high level fistula is where the fistula is opening into the anal canal at or above the anorectal ring. That also is further divided into extrasphincteric or supralevator type, transsphincteric, pelvirectal fistula, etc. The clinical features is, first thing is we will get a past history of perianal abscess. Next thing, the abscess formed, it will be ruptured by itself. Then the condition will heal. Then after a few months, again the abscess is formed, it will rupture by itself. Then there will be a discharging opening left. Like that, after a few recurrent attacks, the discharging fistula will fail to heal and continue to discharge. This condition will develop when the abscess formation is given an inadequate incision also. So in such a condition, when new abscesses are forming, it will result in multiple fistula. And when we see about fistula, a main thing which should be known as the Goodsall's rule. That is, this rule relates the location of the internal opening to the external opening. That is, if the external opening is anterior to an imaginary line drawn across the midpoint of the anus, the fistula runs straight directly into the anal canal. That is, in this picture you can see a midline is there. That is the imaginary line drawn across the midpoint of the anus. And if the external opening is more means the length it is told like a 3.75 centimeter away. So if the opening is present anteriorly, then it is told like the fistula runs in a straight. It will be a straight tract opening directly into the anal canal. And if the external opening is situated posterior to that line, then it is told like it will be a curved tract. The tract usually curve, and the internal opening will be on the midline posterior. So that is the location. And one exception is told like the external opening will be anterior to the imaginary line, but if it is more than 3.75 centimeter away from the anus, then even though if it is anterior also, that tract will be curved, and it will be ending in the posterior midline. That is told in the Goodsall's rule. That is, when we consider an imaginary line in the midpoint of the anus, and if the external opening is above that, that is anterior or above the midline, above the midline, then it will be a straight track. And if it is below, or if it is in the posterior side, then it will be a curved track, and it will be opening into the midline posteriorly. Exception it is told like even though if it is anterior, but if it is away from the anus, that is around 3.75 centimeter away, then even though it is anterior, it will be a curved track only, and it will open into the posterior midline. That is the Goodsall's rule. That is important in case of fistula in anus. And on examination, rectal examination is extremely important in case of fistula in anus. That is, the internal opening have to be felt by the digital examination. And if it is above the anorectal ring, it is high fistula, and it's based on the location, the treatment also will differ. And proctoscopy will also help to visualize the internal opening. And another injection, lipiodol injection into the external opening prior to radiography, if we are doing, that will help to show the track of fistula in anus. And as we have told about, tuberculosis can be a chance of this, means can be the reason for this fistula. So for that, first thing, we can go for a chest x-ray to exclude tuberculosis. And as the fistula in anus can be associated with different kinds of other disorders, it is told like before, means in a case of fistula, it is better to exclude these kind of conditions like tuberculous proctitis, ulcerative colitis, Crohn's disease, etc. have to be excluded prior to the treatment. So for that, whatever necessary investigations can be suggested, that also can be done. And treatment, when we consider for low anal fistula, the fistula tract can be laid open, means after by digital examination, probe can be inserted through the fistula tract, and a probe-pointed director also have to be introduced into the external opening. And while inserting into through the external opening, the tip will come out through the internal opening, and with the help of a knife, the tract can be opened. Means on the dilator, on that probe-pointed director, the tract can be opened. And if there are multiple fistula, the probe-pointed director that have to be passed through individual external opening, and the corresponding tract have to be laid open. That is the treatment as such as fistula tract must be laid open. And later, the means there will be unhealthy granulation tissue will be present, that have to be scraped off, or else the whole tract can be excised also. Later, the cavity have to be packed, and healing will takes place by granulation tissue. That is the treatment for low level fistula. For high level fistula, fistulotomy is suggested based on the types. If it is supralevator fistula, it is commonly secondary to Crohn's disease. So for primary condition, whatever is present, that have to be treated first. And in case of transsphincteric fistula, there will be a perforating secondary tract. So what happens is there will be a lower level fistula also. So first we have to open the lower tract as usual, then only the upper tract have to be made wide, and similarly scraping have to be done, and the cavity have to be packed with antiseptic solution, and healing will occur. And in case of horseshoe fistula, that is, there will be connecting fistulas will be present. In such a case, operation is told like Vanley operation. Vanley operation, that is a posterior midline internal sphincterotomy combined with the laying open the deep part of the fistula tract. That is a sphincterotomy is also done because two fistulas are interconnected. So for that, a sphincterotomy means the internal sphincter will be uh, excised, and then along with that the part of the fistula tract, that also will be laid open. So that is the operation called Vanley operation, that is given in horseshoe fistula. So that is about fistula and its treatment. So these are the intersphincteric fistula, transsphincteric fistula, means based on the location where it is located. Based on that, the naming is given. These are the means when it comes to high level fistula, it will be high intersphincteric, then transsphincteric, supraelevator, etc. So based on the location of that fistula's tract, the names are given, and based on that, the classification is done. So this is a condition where there is multiple fistulous openings are present. So as we have told, when it is low level, each one have to be identified. Each one means the internal opening of each external opening have to, that tract have to be found out, and then it have to be laid open. Next is the hemorrhoids. So hemorrhoids are the dilated veins within the anal canal in the subepithelial region formed by radicals of the superior, middle and inferior rectal veins. Dilated veins, and the involved veins are superior, middle and inferior rectal veins. And the types of hemorrhoids, mainly it is divided into two, internal and external hemorrhoids. Internal hemorrhoids means it is within the anal canal and internal to the anal orifice. External hemorrhoid will be situated outside the anal orifice and it will be covered by skin. And when the two varieties coexist, the condition is called internal external hemorrhoids. That is the one classification based on the location. Another classification is primary and secondary. That is the hemorrhoids when it is located at the 3, 7, 11 positions, means 3 o'clock, 7 o'clock and 11 o'clock positions, relating to the branches of superior hemorrhoidal vein, which divides on the right side into two, left side it continues as one. So based on that, the location is determined 3, 7 and 11 o'clock position. That is called primary hemorrhoids. And the one which occurs between the primary sites, that is called secondary hemorrhoids. And when we see the etiology, it can be hereditary. That is, it can be seen often in the members of the same family. Another thing is anatomical. Means due to the adaptation of that erect posture of mankind, it is told like that is the cause for the hemorrhoids. Then few other causes like straining, then physiological cause like extensive venous plexus are there in the upper anal canal, that can be the reason. And in the diet, when we are including low roughage, then that also contributes to this causage of this hemorrhoids. Then secondary hemorrhoids, it is told like secondary to few conditions, hemorrhoid can happen like carcinoma of rectum, pregnancy, chronic constipation, in conditions which is presented with difficulty in micturition, portal hypertension, etc. Secondary to all these kind of disorders also hemorrhoids can occur. So that is the etiology. And the clinical features, first it is bleeding, and bleeding how it is, it will be bright red, painless and occurs along with defecation. And particularly it is told like the patient complains that it splashes in the pan. As the stool comes out, the blood will splash in the pan. That is the typical kind of bleeding present in hemorrhoids. Next, it is the prolapse. It is a later symptom. In the beginning, the prolapse is minimal, and based on the prolapse, hemorrhoids can again be divided into 4 degrees. First degree, the hemorrhoid does not come out of anus. That is the first degree. Then second degree, it will come out only during defecation, and it will get reduced spontaneously after defecation. Third degree, it will come out only during defecation and do not return by themselves, but we have to replace it manually, then they will stay. Fourth degree, the hemorrhoids are permanently prolapsed. That is, at this stage, there will be a feeling of heaviness in the rectum, and we cannot replace it manually, or it will not stay inside. That is the fourth degree. So that is based on the degree of prolapse. The hemorrhoids are divided into four. And another clinical feature is the pain. It is not characteristic of hemorrhoid, but when there is associated thrombosis or when there is associated fissure in ano, pain is a feature in hemorrhoid. And then it is mucus discharge. That is especially in case of prolapsed hemorrhoids, it is a particular symptom. And means along with the dilated veins, there will be engorged mucous membrane also. Because of that, the mucus discharge is happening. Then because of this mucus discharge, pruritus ana will be caused. So another clinical feature is this pruritus. Then if there is long standing hemorrhoids in a patient, due to that persistent and profuse bleeding, what happens, the patient may develop anemia also. So these are the main symptoms or the clinical features seen in the patient of hemorrhoids. And on examination, internal hemorrhoid, if it is without prolapse, we cannot detect it on inspection. And in second and third degree hemorrhoid, internal hemorrhoids may be seen when the patient strains. The mass will protrude out. And fourth degree, we can see the prolapse files at the 3, 7, and 11 o'clock positions. On digital examination, uncomplicated internal pines will not be felt. We cannot feel an uncomplicated internal pile mass during the digital examination. Only if it is thrombosed, we can feel it during the digital examination. And proctoscopy, that is another important examination that have to be done, that will reveal the internal pile. That is, the proctoscope have to be introduced, the obturator have to be removed, and with an illuminator inside, the inside of the anal canal can be visualized. Then the proctoscope can be withdrawn slowly, and while withdrawing, the internal hemorrhoid can be seen bulging into the proctoscope. Thereby, we can determine the position as such. Then complications, excessive bleeding and thrombosis is the main complication, and along with that, other complications like strangulation, gangrene, separation, fibrosis, etc. also can occur. So this is the internal hemorrhoid and external hemorrhoid based on the position. Then degrees we have seen. This is the first degree when nothing is coming out. Then second degree, which will on straining it will come, but it will get reduced spontaneously. Third degree when we have to manually replace it. Fourth degree when it is completely prolapsed. This is the position, means primal 3, 7, 11, how the flow positions will be. Based on that, how the pile mass is getting arranged. Now it is about the management. So treatment, first of all, if any conditions associated like Crohn's disease, ulcerative colitis, etc., if there is a doubt regarding that, then that have to be excluded first. And if there is associated fissure in ano, that should be excluded. And that should means if there is presence or not, that should be confirmed first. And if it is present, then that have to be treated first. When we consider the treatment of hemorrhoid, that should start with bowel regulation. First of all, the bowel regulation have to be done. In the first degree especially, the bowel regulation is a must. First, we will see the non-operative treatment methods. In that, sitz bath will come. Then local applications to reduce the pain, itching, edema, etc. For that, local applications are suggested. Then antibiotics, laxatives, anti-inflammatory drugs are beneficial. Then fiber-rich diet have to be advised. Then fiber alternatives like bulk forming agents can be supplemented. Then laxatives can be given to soften the bowel motions and to relieve the constipation. That is the non-operative treatments. Then in case of inflamed, permanently prolapsed and edematous piles, manual stretching of the anal canal that can be given, like Lord's dilatation, that can means dilatation of the anal canal to relieve the strain, and all manual stretching can be given. Then another treatment is injection sclerotherapy, that is done in first degree and early second degree piles. As an OP procedure, it can be done using the proctoscope and syringe. 3 to 5 ml of 5% phenol in almond oil that can be injected into the submucosal plane just above the anorectal ring to the pedicle. And all the masses, means how many pile masses are present, that can be injected separately. That is 3 to 5 ml can be injected to each site in a single setting. It can be repeated after 6 weeks. And what happens is the drug will cause fibrosis, and thereby there will be a fixation of the anal cushions, which will not prolapse. We have seen in the same thing, same medicine is used in prolapse of rectum also. Same means same action is happening here also. It will cause fibrosis, and later it will help in the fixation of the anal cushion so that it will not prolapse outside. That is the another technique. Then it is Barron's banding, especially it is done for second degree piles. Means banding will be done, that is at a time 2 piles will be banded. Repeat banding can be done only after 3 weeks. 2 bands are used for pile mass to take care of breakage. What happens is this banding will cause ischemic necrosis and the pile mass will fall off. That is Barron's banding. Then it is cryosurgery using nitrous oxide or liquid nitrogen. Extreme cold temperature is used to coagulate, and this will cause necrosis of piles, which will get separated and fall off subsequently. That is cryosurgery, nitrous oxide or liquid nitrogen. This is carried out with the help of a cryoprobe. Cryoprobe will be available. With that, this procedure is done. Next is infrared coagulation. That is, heat is used to burn the piles so as to allow it to fall off. Infrared radiation are also applied through the handheld applicator, and in specific wavelength chemical changes will be produced, and that will cause blood coagulation within the hemorrhoid. Finally, the hemorrhoid will seal, it will shrink or slough off. That is infrared coagulation. Then laser therapy is there for piles, especially for third degree piles. Then Doppler guided hemorrhoidal artery ligation. It is an advanced instrument that will cure all degrees of hemorrhoids. It will be blocking the blood supply of piles, and thereby it will treat the condition. Then another thing is stapled hemorrhoidopexy. That is excision of the mucosa and submucosa using circular hemorrhoidal stapler. That is stapled hemorrhoidopexy, circumferential excision of mucosa and submucosa using circular hemorrhoidal stapler. Then it is the open operative methods. That is the hemorrhoidectomy. Mainly, hemorrhoidectomy is the best treatment for hemorrhoids, and in the modern terms. And when we compare the other procedure, it is considered as the best treatment, and it is uh, performed in the two techniques, open or closed technique. And open technique means the anal mucosa and the skin are left open to heal by second intention, and closed technique, the wound will be sutured. Same thing only is happening, like ligation and excision of pile is the method used. Under anesthesia, lithotomy position, first dilatation will be given, then skin will be held with the Alice forceps, then internal pile will be held with the artery forceps, skin will be cut in a V-shaped manner, and sphincter will be separated and pushed up, pedicle will be transfixed, and the distal part will be excised. Single sitting only, all the three piles can be dealt. Post-operatively, sitz bath, antibiotics, laxative, analgesics, local applications, etc. are given. Then, so these are the means other newer methods are also there, like ultrasound or controlled energy. Hemorrhoidectomy also are suggested, but these are the main methods which are used in the treatment of hemorrhoids. Next, it is the fissure in ano. Fissure in ano It is a ulcer in the longitudinal axis of the lower anal canal. It is a very common and painful condition. Mainly means commonly the fissures will occur in the midline posteriorly. The midline posterior means it is considered as the least protected part of the anal canal. Etiology, it is told, means especially why the posterior midline is the main location. It is told like because of the posterior angulation of the anal canal, the relative fixation of anal canal posteriorly, then elliptical shape of the anal canal. These are the reasons told for why it is common in the posterior midline. Other causes are constipation, then spasm of internal sphincter, then after operations when too much of skin is being removed, then that also can cause fissure in anus. Other than that, few secondary causes are told like ulcerative colitis, Crohn's disease, syphilis, tuberculosis. These also can result in these also can cause fissure in anus. The types of fissure in anus, it is told acute and chronic. Acute fissure in anus, it is a tear of the skin of lower half of the anal canal. There is hardly any inflammatory induration or edema of its edges. Then anal sphincter muscle spasm is always present in that case of acute fissure in anus. That is a tear of the skin of the lower half of anal canal. Whereas chronic fissure in anus is a deep canoe-shaped ulcer with thick edematous margin. In case of acute fissure, inflammatory induration or edema of the edges, it is not that much significant. But in case of chronic fissure in anus, the specific feature or the most predominant feature is the thick edematous margin. And in the chronic fissure in anus, at the upper end of the ulcer, there will be a hypertrophied papilla. And at the lower end of the ulcer, there is a skin tag that is called sentinel tag or sentinel pile. It is told that sentinel means something which guards, that is, it will be guarding the anal fissure. So it is called sentinel tag, the skin tag present at the lower end of the chronic fissure or the lower end of the ulcer. It is called sentinel tag. The clinical features. So this is a fissure. You can see and about the clinical features, acute fissure, there will be spasm, pain during defecation, then blood, bright streaks of blood will be present along with the stool, or in the tissue paper, the presence of blood will be there. And if the acute fissure fails to heal, what happens? There will be a development of a deep undermined ulcer, and that is called chronic fissure in anus. And as we have told, when on examination also we can see the hypertrophied anal papilla at its upper end, and it's in lower end there will be a skin tag. Pain and bleeding are the two main symptoms of this condition. Pain starting with and following defecation, that it is described how the pain will be, that is described as sharp biting, burning, etc. That much severe the pain will be. The pain will be sometimes intolerable, and the pain means after uh, the severity of the pain, it is told like after the pain goes off, the sufferer remains comfortable till the next action of bowel. That is again during the defecation, pain again will start. Then bleeding, it is variable. Usually it is streaks of blood over the stool, or it will be spots noted on the toilet tissue. Sometimes slight discharge will be associated, and pruritus ani will also be associated with this condition. And on examination, a tightly puckered, closed puckered anus will be present. Sentinel skin tag may or may not be present. Then um, there will be severe pain that the digital examination will not be possible. And if allowed, a chronic fissure is easily palpable by the digital examination. Usually the patient will not allow digital examination because that much pain it will be creating. So once the digital examination is done, we can easily palpate the chronic fissure. And in case of severe pain, if we have to go for the digital examination, it is told that a surface anesthetic like 5% silocaine ointment, etc., can be applied on the anus, and then digital examination can be tried. Otherwise, it will be painful for the patient. And treatment, it is told conservative treatment means if it is an acute ulcer with a short history, then conservative treatment can be done, like oral pain medication, stool softener, then glyceryl trinitrate, that is nitric oxide can induce relaxation to the internal sphincter, and glyceryl nitrate is a nitric acid donor. That so if it is applied as an ointment to the anal canal, that will help in relaxation of the internal sphincter. Similarly, other soothing ointments, self dilatation, then injection of long acting anesthetic solutions, these all can be done as a conservative treatment. In case of chronic ulcers, anal dilatation, posterior sphincterotomy, fissurectomy, lateral anal sphincterotomy, excision of anal ulcer, anal advancement flap, these are the treatment tool in case of chronic ulcers. Next, it is about the pilonidal sinus. So, pilonidal sinus, it is also called uh, G bottom or uh, driver's disease, because it is common in G drivers and all. So, it is given the name G bottom or driver's disease. How it is caused means mainly it is to like the it is caused due to friction or the hairs entering into the uh, mainly it is uh, seen in the cleft region, that is between the two buttocks. The location is told like the common location is like inter buttock sacral region. In case of uh, most of the patients, the site will be inter buttock sacral region, between the cleft it will be. Other regions are also told that it can be mm, occurring in the hands and all, means in case of hairdressers, in interdigital clefts it can be happening, in axilla when the means in axilla hair is present, so there it can occur. In umbilicus there will be hairs present, so there also it can occur. But still the commonest site it is told like it is the interbuttock sacral region. And the pilonidal sinus or that condition, it is a epithelium lined tract. It is situated short distance behind the anus. It will be containing hairs and unhealthy diseased granulation tissue. And how it is caused, it is told it is due to the penetration of hairs. As we explained the site, we understood that it is common in a region where hairs are present. So it is told that it is due to the penetration of hairs through the skin into the subcutaneous tissue, uh, and it is of infective origin. And how the pathology is told, it is told like the hair will penetrate the skin, it will cause dermatitis, that is the infection is happening, then it will result in pustule formation. The pustule will form into a sinus, then hair stucks into the uh, sinus, and because of the negative pressure it will be sucked inside, and the hair will stuck inside the sinus. And further again irritation will be happening, granulation tissue formation starts, there will be pus formation, and finally it will result in a multiple discharging sinuses. So that is the pathology tool. So clinical features from the pathology itself, first thing is discharge is present, it can be serosanguinous or purulent. Then pain will be there, it is something caused due to infection and also definitely pain will be there. And the pain will be throbbing and persistent type. And on examination a tender swelling will be seen. As per our the common location, it will be above the coccyx in the midline and on either sides of the midline. uh, while we open the sinus, tuft of hairs will be present. Then recurrent infection, means there is a chance of recurrent infection abscess formation. Finally it will burst open, presenting as recurrent sinus with the pain, discharge and discomfort. Treatment in the acute phase, it is told drainage of the abscess, antibiotics, and later, if it is not cured, definitive treatment is suggested. In definitive treatment, it is told that the sinus tracts have to be opened and the whatever unhealthy granulation tissue and hairs are present, that have to be removed completely. And it is told methylene blue can be injected to check for if there is any other tracks. Means if there is multiple tracks present, then that can be demonstrated properly with the help of methylene blue that can be injected into the opening. Then other treatments like excision and skin grafting, excision with Z plasty, then excision with multiple Z plasty, VY gluteal advancement flap. So then different kinds of excision techniques are told, but ultimately the treatment is we have to break open the sinus, remove the tract as such, and the entire tract can be excised, and proper wound healing can be uh, done. Means with the help of proper antiseptic solution packing, uh, by we have to keep it open, and proper dressing can be done to ensure the proper healing. So that is the treatment essential for pilonidal sinus. Then it is about the neoplasms of the rectum and anal canal. Most frequent tumors occurring are the polyps. So polyp is a localized elevated lesion arising from an epithelial surface. It can be adenoma, that is 90% is adenoma, and other polyps 10% can be inflammatory, hyperplastic, etc. Two types of adenoma are told: tubular, that is pedungulated, and villous, sessile. That is 80% and 20%. Tubular is 20%, villous is 80%. And the benign conditions, the symptoms told are bleeding, mucoid discharge. Villous type, it is mainly presenting with the discharge and bleeding. Then treatment, it is told polypectomy. That is, if it is pedically present, then it will be easy. Whatever it is, polypectomy can be done by colonoscopy or as surgical excision. When it is sessile, when there is no pedicle, we can go for surgical excision also. That is the treatment of benign rectal tumors, or mainly it is about the polyps as such. Other conditions like hemangioma, that and all are rare. Benign neoplasms mainly involve the polyp only. There are juvenile polyp, adenomatous polyp, villous adenoma, benign lymphoma, etc. Then other rare conditions are also there under the benign tumors, that is endometrium and hemangioma. They are considered as uncommon tumors. Next is about the colorectal carcinoma or carcinoma rectum. Mainly, it is the second most common cancer death after lung cancer. Then the etiology, it is told red meat and saturated fatty acid increase the risk. Then high fiber diet reduces the risk. Then alcohol and smoking will increase the risk. Villous adenoma that have a chance of turning into malignancy. Then other diseases like ulcerative colitis, Crohn's disease. These and all will increase the incidence of carcinoma of rectum. Then family history of rectal cancer, if it is there, then that also uh, will increase the risk. Then other cancers like of endometrium, stomach, etc. In the same patient, if there is risk of developing other cancers, then the risk of carcinoma rectum also increases. That is about the etiology. Then about the spread, four kinds of spread it is told. Local spread, that is, it will spread locally, circumferentially. Later spreads to the muscular cord and perirectal tissue, then to prostate, bladder, seminal vesicles, like that. It will spread. That is the local spread. Then it is about the lymphatic spread. That is about the peritoneal reflection. The spread will occur upwards along the colonic lymph nodes. Then it is venous spread, like other carcinomas of body. It can spread through the blood. So that is venous spread. Then transperitoneal spread. That is high up in the rectum above the peritoneal reflection. It is due to peritoneal metastasis. So these are the four types of spread: local spread, venous spread, lymphatic spread and transperitoneal spread. Then next is about the staging. Staging of carcinoma, two types of clinical staging are there: Duke's classification and TNM system. Duke's classification: stage A, B, and C. A means limited to rectal wall. B extended beyond rectal wall, but there is no involvement of regional lymph nodes. Then C, growth has extended beyond the rectal wall, and lymph nodes, regional lymph nodes are also involved. That is C. C1 means where the local pararectal lymph nodes are only involved. Stage C2 means intermediate and main lymph nodes are also involved. That is the Duke's classification. Next is the TNM classification. TNM, T1 is it is carcinoma in situ. T1 involvement of mucus and submucous cord. T2 muscular wall is involved. T3 all layers of colonic wall including serosa it is involved. Then T4 adjacent structures are involved. N0 is no lymph node metastasis. N1 is regional lymph node involvement. Then M0 no distant metastasis. M1 distant metastasis. That is similar to other carcinoma. Same kind of classification is given for rectal carcinoma also. Another histological grading is there. That is the texture, means normal texture and shape, how much it is uh, having, the less malignant it will be. So seeing the histological findings, and based on the histology it can be graded. It is graded into three: stage 1, stage 2, stage 3. Stage 1 is low grade, stage 2 is average grade, and stage 3 is high grade. Next, it is about the clinical presentation. Clinical presentation, mainly bleeding per rectum or bleeding per anum is there. That is the earliest symptom. Then spurious diarrhea. That is in the early morning due to overnight mucus accumulation. When in the morning there will be a urgency for defecation, but it will result in the spurious diarrhea with incomplete evacuation. That is another main symptom or feature present in the carcinoma. Then it is about the tenesmus, that is painful incomplete defecation with the bleeding, that is tenesmus. Then mucus will be there, mucus mixed blood, that will be present in the stool. Then sense of incomplete evacuation, constipation, anemia, malnutrition, loss of appetite, loss of weight, altered bowel habits. Then sometimes urinary symptoms due to infiltration of bladder or prostate, urinary symptoms will be present. Then back pain, ascites, liver secondaries, urinary symptoms other than that. So these are the main clinical features seen. Based on the metastasis, the different kinds of symptoms will be developing in the patients. Investigations: proctoscopy, sigmoidoscopy, biopsy, barium enema, colonoscopy, then ultrasound abdomen to look for secondaries in liver, to see for ascites, etc. Ultrasound abdomen will be helpful. Then CT scan to see the operability, local extension, size, nodal status, etc. CT scan will be useful. Then endorectal ultrasonography, that will help to assess the local extent of the tumor. Then blood tests like blood urea, serum creatinine, that is for management purpose. Other investigations are also suggested. And treatment, when we consider like cancers anywhere in the body, radical resection is the only curative treatment available for carcinoma of rectum. And that radical excision means excision of the rectum with its sheath along with all the knots lying on the wall. That is the radical excision, radical resection or radical excision. For this, the rectum has been divided into three parts: proximal third, middle third, and distal third. In proximal rectal carcinomas, it is told means the cancers with the lower margin that can be removed by low anterior resection and primary anastomosis. That is, the sphincter mechanism have to be conserved and primary anastomosis can be done. Then in mid-rectal carcinomas, abdominoperineal resection. Then after resection, anastomosis can be done. That anastomosis can be done using stapler technique also. EEH stapler, that instrument is available that will help in doing the end-to-end anastomosis. In case of distal rectal carcinomas also, abdominoperineal resection or perineoabdominal resection is the method of choice. Abdominoperineal resection, the procedure is detailed in the notes. Once you go through the notes, if you are not getting an idea, we will discuss later. Then those are the main treatments. Means according to the site, site of the carcinoma, the treatment is suggested. And other than this resection, then other procedures like radiotherapy, chemotherapy, immunotherapy, that are also suggested. Radiotherapy, that is preoperative radiotherapy, 2000 rats in week, that can be given, and intracavitary radiotherapy can be administered. High doses of radiation that are precisely delivered to the patient. And chemotherapy, mainly it is the 5-FU, 5-fluorouracil, that has been infused into the portal vein during and immediately after the primary operation. Other drugs are also there: systemic folinic acid, leucovorin, then levamisole combination. So such kind of drugs are also used for chemotherapy. Then immunotherapy is there. There is various monoclonal antibodies to carcinoembryonic antigen that is used to destroy the cancerous cells. Then certain other operations are there, like Hartmann's operation, extensive operations. In case of males, there will be total cystectomy and resection of rectum. In females, it is a total hysterectomy. That is to wherever the spread is happening to the adjacent organs. Based on that, extensive operations are suggested to remove the adjacent organs which are being affected. Then certain stents are available. Self-expanding metal stents are available to relieve the acute obstruction caused due to the surgeries and all. So these are the main treatments told in case of carcinoma rectum. And in addition to that, Arshas and Bhagandara is there. Arshas and Bhagandara, in notes it will be detailed. Means main things you have to know is main thing how, means first it is about Arshas, then it is told something which is which produces fleshy growths in the Buddha valleys, that is called Arshas. Nidana, it is told Samanya Nidana and Vishesha Nidana are told. Samanya Nidana, Guru Madhura Shida Vidahya Ahara, then Vyayama Diva Swapna, Basti Vibhrama, those kind of Nidanas come under the Samanya Nidana. Vishesha Nidana, based on the dosha predominance, the Nidanas which will cause the Visheshan of respective doshas. The Nidana is classified into Samanya and Vishesha. Purva Rupa and Shraddha, Krishna, Bhakti, Amlika, Paridaha, Vishtambana, Vipasa, Akshishvayedu, Antra Pujana, etc. The Purva Rupas told for Arshas in the Sushruta Samhita. Then the Lakshana, it is told for Vataja Arshas, it will be Parishushka. In Pittaja, the appearance will be Neelagra Praklina. Then Kafaja, it is Vritta and Snigdha. Raktaja, it will be same as that of Pitta Lakshana only. So Vataja, it will be little dry, means the Vata predominant features will be seen, like it will be Parishushka, dry. Then the color it is told like Kadamba Pushpavat or Tundigeri Pushpa it is told. Then the color it is told Aruna or Vivarna it will be. And how the bowel habits, it will be Sashula Samhata Purisha. There will be pain during defecation, and also there will be pain in the Kati, Prishta and Guda region. Then in case of Pitta, it will be Neela Agra Praklina. There will be a bluish discoloration. There will be the appearance or the shape it is told like Jaloka Vaktra Sadrisha. It will be similar to the mouth of the Jaloka. Then the color it is told like Yakrit Prakasha or Pita Vabasa. It will be the color similar to that of liver, or it will be having a yellowish discoloration. Then there will be more of sadaha sarudhira purisha. There will be more of burning sensation and bleeding will be present during the defecation, and associated with that jwara, daha, pipasa, etc. also will be present. In kafaja, it will be the appearance will be vritta and snigdha. It will be circular or round in shape, and it will be snigdha, and the appearance, it is shape is similar to karira panasa asti or gostanakara, it is told. Then the color will be shweta or pandu. Then how the defecation will be, it will be analpa, then srava will be there, then avagada purisha, it will be um, means bulky defecation it will be. And complications, it is told like associated with these features, there will be shofa, shita, jwara, arojaka, etc. experienced by the patient. And raktaja, the features similar to that of pitta is told. Samprapta, it is told due to the Nidana Seva, what happens? The Vatadi dosha prakopa will be occurring, and along with Dushta Rakta, this Prakupita dosha will move in the Pradhana Dhamani, that is the Purishavaha Dhamani will be affected, and it will reach Guda and producing Gudavali Dushti. And that will finally result in Mamsa Praroha, and the enlargement of this Mamsa Praroha will result in Arshas. So Nidana Sevana, Vatadi dosha prakopa, along with the Dushta Rakta, this Prakupita doshas will move in the Purisha Vahani Dhamani, reaches the Guda, produces Gudavali Dushti, and resulting in Mamsa Praroha. Chikitsa, it is told, Nidana Parivarjana is the Chikitsa tool. Then other than that, internal medicines it is given. So many Bheshtaja Chikitsa is given by Acharya Sushruta. Means the medicines to improve the acne, to regulate the bowel, to treat the symptoms like Rakta Sangraha Dravyas are told. Then for pre-operative use, for surgical and parasurgical measures, medicines used for pre-operatively and for post-operatively. Such kind of medicines are described by Acharya Sushruta. Then local treatment, it is advised to relieve the pain and local congestion. Abhyanga, Svedana, Basti, Dubana, Avagaha, Pralepa, Parisheka, etc. are also told. And when we see the treatment separately, means main treatment, it is told like Chaturvida Sadhanopaya is told. Chaturvido Arshasam Sadhanopaya Tadyada Bheshajam Ksharam Agni Shastramidi. So Bheshaja Chikitsa, where it is indicated, where Kshara Karma is indicated, where Agni Karma is indicated, and where Shastra Karma. In which kind of Arshas, these four types of treatment can be suggested. That is detailed in notes as such. Just you go through that. Then it is about the Bhagandhara. Bhagandhara, it is an eruption in the area of pelvis, rectum, and urinary bladder. And when it is not open, they are called Pidaga. And when they are open, it is called Bhagandhara. Nidana, same thing. Aharaja, Viharaja, Agandhujan, Danas are told like Kashaya, Ruksha, Ahara, Apatya Sevana, Viruddha Ahara, Ativyavaya, Pravahana, Utkatakasana, Hasti, Ashwa, Prishtagamana. These kind of Nidanas will cause Bhagandhara. Samprapti, it is told due to Apatya Ahara and Vihara, the Vayu gets vitiated and gets localized around the Guda, and it will vitiate the Rakta and Mamsa at that area and will give rise to Pidaga. According to the dosha vitiated, it will result in Pidagas. And if the Pidaga is not treated in time, and if the person is continuing to expose to the Nidana, then the Pidaga will get Pakwa and it will burst open, causing the disease Bhagandhara. The types of Bhagandhara, it is told. First one is Shataponaga. Due to the Nidana, the Vata gets aggravated. It will localize in the in 1 or 2 angula around the anus, vitiates the Mamsa and Rakta, causes Pidaga, and the Pidaga will be light red color. It will be associated with pricking and other kinds of pain. And if not treated in time, it will undergo separation. And since it is nearby the urinary bladder, the prana will become moistened, through the minute holes, and from the opening there will be exudates coming, that is continuously a clear frothy liquid which will be in great quantity that will be coming out through the openings. And the patient complains of severe kind of pains, and if the condition is neglected, then flatus, urine, feces and semen will start coming out of these openings. This kind of bhagandara is called as shataponaka bhagandara. Then it is about the Ushtragriva Bhagandara, that is the second type. That is the Pitta getting aggravated, that is pushed down by the Vata, becomes localized in the areas and will cause Pidaga, which is red in color, thin, elevated, and it will be shaped like an Ushtagriva. Ushtagriva means camel neck. So, and there will be mm, symptoms like there will be sucking kind of pain, and if it is not treatment, separation will happen and it will result in a brana, or it will result in an opening, and there will be daha associated. Then fluid will be exudating outside, which will be having a bad smell, and it will be ushna, means it will be warm. And if neglected, same thing, flatus, urine, feces, etc. will be coming out. That is Ushtragriva Bhagandara. Then Parisravi Bhagandara, here the kapha will be getting aggravated, and that will result in the Vedaga, which is white in color, which will produce itching with the mild pain. The opening or the ulcer formed will be hard, swollen, and it will be more of itching, and exudates will be slimy in nature. That is Parisravi. Then Shambhugavarta means Vata gets aggravated, combining with Pitta and Kapha. It will move downwards, get localized in the areas, and form the Pidaga. It will be big. The size will be big, like almost the size of a big toe, and it will be having the features of all the three doshas. It will be associated with Vedana, Daha, and Kandu. If it is not treated in time, it will undergo separation and it will form ulcer, and that will exudate fluid which is having different color, which will produce different kind of pain, and it will resemble the Shambhugavarta. That is why it is called Shambhugavarta Bhagandara. Then the other type is called Unmarbi Bhagandara. That is, the Nidana, it is told like a foolish person who is being greedy of meat, when he consumes the meat along with the pieces of bones and other foreign bodies, uh, or whom the feces have become very hard, these are pushed by the Apana Vata, and that will the Apana Vata will be moving in a Vimarga. It will be moving in an improper manner. It will reach the rectum and it will produce a wound. And because of that wound, there will be sloughing of the muscles. There will be sloughed muscles presence, and there will be flow of pus and blood along with that. And such a Vrana, from this opening, what happens? There will be worms will be appearing. Means worms will be developing at that place, and from these openings, what happens? Flatus, urine, etc. will be coming out. This kind of Bhagandara, it is called Unmargi Bhagandara. Then another type is called Parikshepi Bhagandara, that is Vata Pradhana Bhagandara. It travels around the Guda, and it will be resembling like a host to type, means interconnecting fistula it will be. So host to type of Bhagandara it is told, and that will be description of this variety is based on the clinical status. Then Riju Bhagandara, it is a Vata Kapha origin. It forms a straight fistula causing tear in the Guda Pradesha. Then Arsho Bhagandara, it is caused from the vitiated Kapha and Pitta dosha. It will be it will be along with the previously existing Arshas. That will give rise to swelling, itching, and burning sensation. It will separate, form a fistula, and it will soften the roots of Arshas and begin to eliminate fluid constantly through the sinuses. So these are the different types of Agandhara told. And about the Sadhya Sadhyada, Shambhugavarta and Unmargi are considered as Asadhya, but remaining all are Kritra Sadhya. Chikitsa, preventive measures are told. Means in the Apakwa Avastha, some measures of Shashti Rupakrama can be done, like Alepa, Apatarpana, Parisheka, etc. That is Apatarpanadya Virejananta. Means starting from Apatarpana to Virejana, what all procedures are told, those can be given in the particular condition. Then curative measures, that is preventive measure, that is in the apakwa avastha to prevent the bhagandara formation, that can be done. Some curative measures are also told like virejana, yeshana, patana, margashodhana, tailadaha, kshara etc. For medical management, Varti is told, then Lepa is told, Gugulu, Trufala Gugulu, Saptamikshaka Gugulu, Navak Karshika Gugulu, these kind of Gugulus are told. Then Taila is told, Rasa preparations are also told for the medical management. Then surgical management of Bhagandara, it is told in 3 steps, Purva Karma, Pradhana Karma and Paschat Karma. In Pradhana Karma and Purva Karma, Snehana can be given, Avagaha Svedana can be done, Lankhana and Anuloma before the surgical procedure. Then instruments, Bhagandara Yantra can be collected. Then Pradhana Karma, the anus should be lubricated and Bhagandara have to be examined. Then Ashani Yantra can be introduced into the external opening and the tract can be excised. And in case of Avachina Bhagandara, the Bhagandara Yantra can be introduced into the Buddha and the patient have to be asked to strain down and the internal opening have to be identified. And similarly, Ashani can be introduced and the whole tract can be excised. That is the Pradhana Karma. Based on the location of the internal opening, the procedure will differ. And after the procedure, Parisheka, Sweda, Avagaha Sweda, Vranashodhana Lepa, these kind of procedures also can be done. Another important treatment tool for Bhagandara is Kshara Sutra. That is, after assessing the tract with the probe, the needle have to be introduced along with the Kshara Sutra till the end of the sinus is reached. The needle is lifted up, the end of the thread is pulled out, and the knot is tied. Kshara Sutra can be changed once in a week, assessing its strength and procedure, and that can be continued till the tract gets cut completely. And in case of Bhagandara, the patient should avoid excessive physical exercise, copulation, anger, riding on animals and foods which are hard for digestion for at least 1 year. That is for the healing of that wound. A 1 year have to be given, and the patient should not follow these kind of apatya, ahara and vihara. And Pathya it is told Shalidhana, Mutka Patola, Shiggu, Balamulaka, Tikta Varga, Tila, Tila Taila, Sarshvara Taila, Vilepi, Krita, Madhu, etc. can be. It's about Arshas and Bhagan. Uh, Today or tomorrow you will be getting the notes. Once go through it. And if there is any clarifications required, is there any doubt?
Hmm.